more than 30 years of experience consulting, designing, and operating programs serving individuals with disabilities throughout the country. Some of Mr. Cook's most notable accomplishments include his experience as policy analyst and lead grant writer for the Illinois Council on Developmental Disabilities, his work with Dungarvan, a disability service provider based in St. Paul, Minnesota, where he served for 5 years as regional director for operations in Delaware, Illinois, Indiana, New Jersey, and Wisconsin. He also worked as an independent consultant in Medicaid systems change projects with state and local governments and private agencies in Arizona, Delaware, Idaho, Illinois, Maryland, Minnesota, Pennsylvania, and Wisconsin. He currently serves as the Executive Director of Rehabilitation for Wisconsin in Action, a statewide nonprofit membership organization of disability service providers headquartered in Madison, Wisconsin. Under Cook's leadership, RFW in Action was the first organization to support calls for a legislative audit of family care, Wisconsin's managed care long-term care program for frail elders and people with disabilities. He also serves on the Access Board of Directors, which is the National Association of Disability Service Providers. Mr. Cook is here to provide us with insight on what New York State and its key stakeholders can learn from the experience of other states that have implemented managed care to support individuals with developmental disabilities. Please join me in welcoming Mr. Cook.
Good morning, everybody. Hope you can hear me better than maybe in the last session. You can hear me all the way back there? That's cool. Okay. I want to thank Paul for inviting me to participate in the symposium. I have some information to share. Paul was talking about cataclysmic climate events, and I think one of the climate events that we're experiencing in Wisconsin in our managed care program right now is a big drought. It's a money drought, and of course that goes along with the other drought we're experiencing there. I do want to point out that I have a colleague here in the room, actually one of my bosses on the RFW in Action's Board of Directors is here. If you could raise your hand or stand up. Patricia Fabian is with us today. And if after my presentation you can't interact with me and you want to ask questions about our experience with Medicaid managed care, she'd be happy to entertain any questions or remarks from you. First, I wanted to say that there is kind of a connection here between Wisconsin and New York State, and that is in the person of Jason Helgerson. Jason was our Medicaid director under our former governor, Jim Doyle, and when Governor Scott Walker, who some of you in the room may have heard of, was elected, of course, Jason was on the job because it was Democrat to Republican in our state. In fact, it went entirely from blue to entirely red. So we call Wisconsin a purple state. But Jason then became the Medicaid director under Governor Cuomo. And of course, one of the things that, in fact, I got a call shortly after that happened from somebody in New York City who I interact with on the Access level, through the Access organization. And he said, well, what can you tell me about this Jason Helgerson guy? And I said, not much. He didn't have a lot to do with long-term care in our state. But I think he wanted to import some models from Wisconsin into New York, and I think that's maybe why some people have asked me to come here and speak in the past. I spoke actually at a nicer event, Spring Policy Institute in June of last year. I wanted to start with this timeline here, recognizing that some things have changed and put it behind. Paul and I were just talking a little bit before the session about the fact that originally People First waiver was conceived of as an 1115 demonstration waiver, and now there's discussion about making it a 1915 DC, which is another form of doing a waiver. 1915B kind of covers the managed care aspects, and the C does the waiver part of it. But if you look at the timelines here, they seem pretty ambitious. And first of all, who thought of the name DISCO? I mean, really? Developmental Disability Individual Support and Care Coordination Organizations. Okay, that's quite a name. Hopefully people don't think of Studio 54 and other examples of DISCOs. But anyway, DISCOs are the organizations that would be formed to coordinate care. Under the original proposal that was made. And in fact, when you look at the timeline here, I'm just going to scroll through it a little bit. Whoa. Didn't think it was that upset. So by now, it says that the DISCO pilot contract template should have been approved by CMS. Well, that's not even in place yet. So you can see July is where we're at in 2012. Final DISCO selection notification, no. Care coordination model guidance posted on the Office of for Persons with Developmental Disabilities website, which is a good place to visit. If you don't visit that, regularly, you should go there and really check up on the updates there. Commissioner Burke is relatively new at her job, and she inherited quite a job. If you look at the New York Times exposés that were done on quality of care and so forth, she really came in at a critical time. But at any rate, one of the things that's happening here, it says August readiness review begins. They haven't even got the applications yet, so they can't begin readiness reviews. But one of the things that I am aware of, and this is through a connection I have through some consulting work that I continue to do, one of my consultant colleagues actually has been in Albany talking with the commissioner about how to structure payment rates under a managed care model. So when I heard that, I thought, well, maybe this won't turn out so bad, or maybe it won't turn out like it did in Wisconsin, which is the drought part that I'm going to get into now. But if you look ahead here, you see that actually pilots are supposed to be in operating March 2013. I would imagine that's going to get pushed back. There should be a statewide DISCO RFA contract by March of 2014. Rollout of DISCOs to larger parts of the state is supposed to happen around about then. Launch statewide DISCOs, the target date was originally February 2015. Now they may catch up at that point. But that's kind of the ambitious timeline that they've set forth, and I think they slowed down for a good reason. One thing that I'm aware of is that CMS had some concerns about in 11-15 late. And so they had to go back and they had to say, well, what are we going to do about that? And that was one reason they slowed down. And another reason I think they slowed down is they were relatively new as state government employees. They needed to figure out the system, how it worked, and maybe some things that might work, make it work better. As I was listening to the first presentation this morning, one of the things that struck me was the fact that integration was mentioned so often. And I think that that's a precursor of things to come, certainly. But it's very interesting from the standpoint of view. I was in the Washington, D.C. area in March of this year. And I gave a presentation on March 1st, or February, actually it was February 29th, it was a leap year. And it was at the World Congress for Medicaid Managed Long-Term Care. And Thomas Johnson, who's the chair, he's I think the CEO of Medicaid Health Plans of America. If you go to their website, you can find out some information about that group. But it was interesting in view of what we heard this morning as the Accountable Care Organization sort of being a potential model for the future, and maybe one that's starting to accelerate because of the investments that are being made. Thomas Johnson, the head of the Medicaid health plans, all these private organizations, these private insurers who have been doing long-term care for the frail, elders, and people with physical disabilities around the country, as well as all the acute care side, because most Medicaid acute care is now provided under a managed care model, said that he thought that the ACO was the greatest threat to managed care. So, what I'm going to talk to you today about is really how not to go down the same path we went down. And so I'm going to be the person who scares you a little bit. First of all, why do states view managed care as a solution? Well, the biggest reason is because they want to gain more budget stability. When Medicaid is the biggest single line item in their state budget, there's an obvious issue that needs to be dealt with. So by capitating the rate and then turning over responsibility to care to a managed care organization, they are able to limit their financial risk by passing it all off to contractors, these managed care organizations, by paying a per person per month basis. So that's the capped rate that Patrick just talked about. The other thing is that they ostensibly can hold the entity, the managed care organization, accountable for controlling two things, the service use and providing quality care. So that's the way it's supposed to work. Let me tell you a little bit about how Wisconsin's managed long-term care system developed. Governor Tommy Thompson, who we all know became the Department Secretary of Health and Human Services under George Bush. He was the first HHS Secretary. Before he went there, he envisioned family care in the late 1990s as a reform of our long-term care system. At that point, all of the long-term care was being run under a waiver program, 1915C, by the counties. And originally, his proposal generated quite a bit of opposition, both from the counties who were running the programs and from the advocacy community, as well as the providers who were, afraid of what was going to happen. Because the way he thought about it was, we're going to put out an RFP, we're going to select one health insurer to cover the whole system. So that would have been a United Healthcare or a WellPoint or one of those organizations that really does want to get into this market. And based on that opposition, in fact, I remember some of the town hall meetings where people got up and basically screamed at the state officials that were saying, we want to go this way. Some changes were made, and the program began as a pilot program under 3 different 1915C waivers. So one of the things that we had to do in Wisconsin to satisfy CMS concerns was to make sure that there was a self-directed support alternative to managed care. So if managed care didn't work for people, they could go into what we call the IRIS program, which is the self-determination program. Now, I think this is pretty interesting in view of the goals we saw for national healthcare reform. Access, quality, and cost effectiveness certainly were on top of what they were trying to accomplish with the Affordable Care Act. We added one more thing, though, to that, and that was choice. We were supposed to be giving people better choices about the services and supports that were available to meet their needs. Now, in many parts of the state, in a county-run system, some parts of the state, we have counties that put in extra money, which we call the overmatch. And the overmatch really was used to help draw down more federal resources. And in other parts of the state, there was no overmatch. And so in those circumstances, some of the things that happen in the more progressive counties, like Dane County, where I live in Madison, were not able to be done. So for example, supported employment was not a big program in places like Iowa County or Grant County in the southwest part of the state. But it is almost a guarantee that somebody who is graduating from high school in Madison, Wisconsin goes right into supported employment. They don't go into a center-based program unless they have very significant disabilities. So these are the waivers that are currently there. I'm going to skip over that. That's on your slide. It's just reference information. You can actually look these up on the Family Care website if you want, or not the Family Care website, but the CMS website if you want more detail on them. It tells you when the expiration date is, and you can actually look at all the categories that are required by CMS in order to provide a waiver to the state. Does everybody know why it's called a waiver? Anybody know? Why is it called a waiver? You know.
It's called a waiver because it varies from the required state plan that Medicaid requires federal for everyone.
That's right. So Bill gets the gold star. And he said it's a waiver because it varies from the state plan that has been submitted for Medicaid services. In fact, the only entitlement that has existed in the past to Medicaid services was in the institutional program. So that's the other thing, is a person who is participating in a home and community-based waiver is basically waiving their right to that institutional placement. And that right has been kind of one of these things that is questioned right now in terms of litigation, because if a state no longer has institutions, what's the right to service? In Wisconsin, what we decided to do under these waivers was, once we addressed the waiting list, in other words, we took everybody off who was identified through the county system as needing service eventually. Once we identified all those people and then took them off the waiting list, and initially it was a 2-year period that the new counties had to take people off the waiting list, so the managed care organization would take over responsibility from the county system, and they had 2 years. And then as budget difficulties began to occur, they had 3 years. But once that happened, then anybody with a physical disability, intellectual and developmental disability, or a frail elder who met both the financial eligibility standards as well as the functional eligibility standards. It's an entitlement. So we have a number of counties right now in Wisconsin where long-term care is an entitlement. You can imagine what that might cause in terms of a problem, right? Because that's a lot of people. So after it was piloted in 5 counties, in 2005, the program began to expand. It's not in all of our counties yet. It's like one of these, in fact, there was a guy that got up and was speaking to our Department of Health Services Secretary, actually Deputy Secretary, and said, you know, family care has developed like as if you were trying to fly a 747 and building it at the same time. It may have caused some of the problems in terms of how it was rolled out. So after there was a redesign in which there were organizations that were invited, much the same as what's happening now here in Wisconsin, in New York, in terms of the DISCO RFPs that we anticipate going out. There was a request for information from organizations within the state of Wisconsin that might want to coordinate care, and they were required to respond on how they might do that. And that led to an RFP. And so as the RFPs were granted, as the proposals were reviewed and awards were made, we eventually developed 9 managed care organizations out of pretty much existing nonprofits that were either serving people with, who were frail elders in the community. And in Dane County, it was an organization called Elder Care. In Milwaukee, it was an organization called Community Care. And almost all of them have care in their names. And one of the jokes we make is sometimes they don't care. Anyway, so there were 8 new managed care organizations were formed. And Milwaukee County's Department of Aging was the only pilot county that continued to operate a managed care organization. Initially, the program was spending roughly $250 million a year for the 5 pilot counties. Now it spends $1.5 billion a year for 43,520 people. This is as of April. I didn't update figures, but they're probably relatively stable. Roughly 38,000 of them were members of managed care organizations as of April 1st. And that was 18,222 people who were elderly, 12,991 people with intellectual and developmental disabilities, 6,133 people with physical disabilities, and for some reason we can't figure out the rest. 501 people were unknown. There were 5,673 people in IRIS as of March 31st, 2012. That was the alternative program. I forget what that stands for. It's I respect, I self-direct. Yeah, I respect, I self-direct. It's an acronym. And initially, people were going over there because they weren't really being funded as they should have been under family care, under the managed care organizations. So we had much greater growth in IRIS than we had anticipated. And that led to some problems because they weren't set up administratively for that growth. It was sort of set up to be maybe a 1,000-person program. Now it's 5 times that size. And in fact, one of the plans the current administration had made was to double or triple the program size. So that would require a lot more infrastructure. And some changes have been made in IRIS since Governor Walker came into office. So what we started to see, though, was because of that rapid growth and the fact that many of these organizations actually drew down their reserves in order to help fund that expansion. One of the things we saw was that these new managed care organizations had a different profile than the pilots. For one thing, if you think about the legacy waiver program, it was all operated by the county, so they had the county infrastructure in place. They had county buildings, they had county IT systems, they had county HR personnel systems. Well, these new managed care organizations, they either had to expand their existing organizations, or if they were a startup, because there were some that were formed as county alliances, they had to set up a whole new structure. They had to have office space, they had to have computer systems, they had billing systems, et cetera, et cetera. So the state's Department of Health Services initially responded by saying, you're not doing it right. You guys need to bring care under management, damn it. And so that became the phrase for a while. Well, the reason why we're having these financial problems is because you haven't brought care under management yet. It's all your fault, you MCOs. That has basically transitioned into something that they call trying to achieve benchmarks. So they're trying to set these benchmarks against which they are judging the success of the NCO in terms of the cost profile. One of the changes that was made actually in the capitation formula, and this was only revealed because in a meeting with Jason Helgerson and the Assistant Administrator of Long-Term Care for the state, I asked a direct question. This was when Jason was in charge of finding $650 million in cuts to our Medicaid budget. And I said, well, how much of that's going to come from long-term care? And what they said, Freddie Bove was the Assistant Administrator, she said that they were changing the funding of the NCOs to reduce funding by somewhere between 8 and 15%. She didn't have a definite figure, but she thought it would be in that range. So those funding reductions were supposed to be made in 2009 and 2010. During that biennium, we operated on a 2-year budget in Wisconsin. Well, because of some of the things that started happening with providers not getting increases in their payment rates for several years, even though costs were continuing to go up, and some feeling that there was a lot of duplication of services, which is mentioned here. There was an appeal made. In fact, there was a state representative, based on the complaints she was receiving from one of the catchment areas for the managed care organization, basically said, I think we need a legislative audit of this program. And this is some of the testimony that came forward, was that there was a lot of duplication of services. For example, each of the care management teams was required to have not just a social worker, but also a nurse. And so the nurse essentially was a paper pusher. She would show up to the meetings and maybe she'd take a blood pressure or do a little bit of an interview with the person, but she had no other responsibility or role other than to be there as the health designated professional on the team. Well, almost everybody who was in services at that time had a nurse or had a relationship with a doctor in a clinic of some kind. So that was one example of duplication. One that strikes a little closer home to our provider association was that we had the benefit of having the largest share of Medicaid infrastructure grants in the country, maybe because Tommy Thompson set up that formula while he was HSS secretary. Maybe, I don't know. But we got about 40% of those funds. And we're not 40% of the population, I can assure you, in Wisconsin. So at any rate, we had all this mad money to spend, and one of the ways that the state spent it was on a Pathways to Independence program that funded employment specialists. Each managed care organization had an employment specialist who would sometimes come into a center-based program, for example, and say, wouldn't you like to work in the community, get people all excited about it, and then there'd be nothing that would happen. And it was terrible duplication of service, raising people's hopes, really not achieving the outcomes, and another example of duplication. Payment rates were mentioned to service providers. Reductions were being made at that time, 2 years ago. There were multiple conflicting requirements of service providers by the different MCOs. If you had a single program, nursing homes said this a lot, they would have people who were being funded by various managed care organizations, and each of the nurses or social workers that would come into the facility would tell them to do business a different way. So when you have 9 kind of cooks in there, working on the broth, sometimes it doesn't actually look like it's a coordinated program. And then there were specific issues for people with intellectual and developmental disabilities. One of the things that came up was that we weren't really assessing their needs given the assessment. Now, you have the inter-RAI, I think, that's been targeted here. We might have some similar issues with that because it's really not built around support needs for people with developmental disabilities, and there's a conflict in many regards with how the managed care organizations see their responsibility for people with developmental disabilities. They don't really get the community integration part, which is a concern. I mean, Paul mentioned that we had heard the Department of Justice and CMS talk about what their expectations were, very different from what the managed care organization's expectations are. So, and I don't want to paint an entirely bad picture of family care because it has taken people off the waiting list. It's good in about half of the state. It's the other half of the state that I think we need to look at. Long story short, in response, the Legislative Audit Committee authorized an audit. We got the report in April 2011. Frankly, we were disappointed in the report because it really didn't have a lot of detail, really didn't provide a roadmap on how to fix what was going wrong. In fact, we're still trying to get our arms around that. But there were 3 managed care organizations that were being flagged as being at risk for financial insolvency. Well, that's a pretty serious thing, because that's like the Office of the Commissioner of Insurance coming in and doing a test of their reserves and other aspects of their operating budgets and seeing, frankly, that they don't know how they can continue. The report said that access to long-term care was improved. A number of people were definitely taken off the waiting list, so it hit that access issue real well. But the cost effectiveness and sustainability of the program were difficult to assess, according to them, and they required the Department of Health Services then to come back with additional data and plans to try to make the program more cost effective and sustainable. Now, one of the things I think that you really need to pay attention to as managed care is rolling out here in New York State is, okay, everybody's focused on what's going to happen with the capitation, but when you're talking about provider payment rates, you can have a fee for service within a managed care system. The capitation goes to the managed care organization. They have to contract with service providers, and probably the most efficient way to do that is to set up a fee for service, because you don't want to negotiate every contract. Well, in this case, what was happening was, the question was, are rates sufficient to maintain an effective provider network for long-term care services? And they cited 3 things. There were a lot more that they heard about, I can tell you that, because I was in some of those meetings. They cited unreasonable rate reductions, and in one case, a 1-to-1 supervision rate was cut from $29 to $19 an hour without any kind of justification. They cited delay in service authorizations being made, and they even cited payment reductions, such as a notice that was given on October 27, 2010, that the provider's rates would be reduced in like 3 days. Now, one of the things that also came up in the report, and this actually made the Milwaukee paper, the Journal Sentinel. They actually published the top 10 salaries of managed care executives. That was data that came out in the report. There were questions about the administrative costs. When I looked at it, though, I felt that probably wasn't the biggest issue. I think the biggest issue was the combined cost of administrative functions and the care management functions, which we thought had been overbuilt. And initially, when we started looking at this, which was in the spring of last year during the legislative session, right after that audit report was issued, it looked like those expenses, combined expenses, range from about 14% to 22% of the per member per month capitation payments being received by the MCOs. Now they're saying when they average them together across all the MCOs, it's about 15%. And they also object to me characterizing it this way, because they say the care management piece of it is a service cost. Well, excuse me, but that's not the service that's directly benefiting the people in the community, and that's what I'm saying, is that that's money that's pulled out of the per person per month cost in order to operate the MCO. In addition to these funds, which are diverted from direct services, the MCOs must take away money for insurance reserves. They have to have a mandated insurance reserve. Many of them drew that down during the expansion, and it's been really difficult to build it back because of the reductions in funding that took place. So let me just give you an example of what kind of impact. If you had a $3,400 per member per month, which is kind of about the average in Wisconsin, at 14% overhead, which is lower than what they say it is currently, that leaves roughly $2,900 left for services on a per member per month basis. If it was 18%, obviously on an average basis, some are going to be that high. $2,788 would be left for services, and at 22% overhead, which I don't think they have anymore, $2,652 would be left. So there were some changes in 2011. In fact, some changes that got Governor Walker and the Department of Health Services into some trouble with the federal government. Wisconsin's state fiscal year 2012 budget called for freezing the expansion of family care, so it was not going to go into new counties. There are 12 that are still out. 12? I think there's a few more than 12. So anyway, but there's a number of counties, including Dane County and Brown County, where Green Bay and Madison are located, that are not in the program. They also capped enrollment, so what that meant was that people could no longer come off the waiting list into family care. And they intended to expand the IRIS program, doubling or tripling, as I mentioned before. But then there was a letter from CMS that was received by our state government in December of last year, which ordered the state to lift the cap. Now, we had to go through some legislative hearings to, change the laws that were in place, that basically were put in place by the budget. And during that period, when questions were raised about, well, how much more is this going to cost in our state budget, in the next 2 years, the Department of Health Services said nothing. It's not going to cost you anything to continue to take people off the waiting list, which meant that they were going to find additional reductions in the program because that's the only other thing they could do. Now, here's you're not going to be able to see this pretty well, but you can see that there's red ink right there. Everybody knows what red ink is? Those are reductions, okay? And when you look at it, it hits some organizations heavier than others. So we've got two different kinds of capitations that are done. One is that if a person has a functional assessment that says that they should be eligible for nursing home level of care, that's one rate, and that's where most people are in the program. There are some people who don't quite meet that standard in terms of what the long-term care functional screen says about them, so they're in the non-nursing home rate, but they still need some kind of service. And usually that's a pretty minimal service they get. All of those were reduced. And there were some areas, like if you look here, on that line, you see there's if you can read it, there's a $469.41 per person per month reduction. Well, that's pretty big. Overall, though, the department says it was a 1% reduction overall. Well, okay, so let's do some critical thinking here. If you have a 1% reduction in the managed care organizations that are contracting with service providers, and you have escalating costs for gasoline, for workers' compensation costs, if you have a progressive wage scale that allows people to get increases from year to year, all those things cost money. So what that means is probably, even if you just take the core rate of inflation, it was probably like a 4% cut because they didn't increase it. Now, the other thing that they did simultaneously was to say, here's how we're going to fix this. Here's how we're going to fix these issues. Legislature, and it's the Joint Committee on Finance that has the responsibility for overseeing this in our state. And so they said, we're going to seek reforms and saving measures that would help make the program sustainable and keep the program consistent with the interests of current and future program participants. They held town hall meetings. It's kind of a favorite thing for them to do, is to go out and listen to people and then do whatever they want. And they put forward long-term care sustainability reforms in these particular areas. I'm going to focus on residential services because that's the crux of some issues that are occurring currently. But they put forward plans that they said over time would result in sustainability and savings in each one of these areas. So, if you look at the residential services reforms part of it, and they projected savings for this at $14 million general purpose revenue, which is state dollars. And if you put the federal match in there, they're really projecting a $36.4 million reduction in residential services over time. Now, what they told us was that does not apply to the current residents. It's not supposed to apply to people currently receiving services. So bear that in mind as we go forward here. And they made a statement in their plan that said the cost of care provided in residential settings, which included adult family homes, community-based residential facilities, residential care apartment complexes, and assisted living, is a significant cost driver in family care, IRIS, PACE, and partnership. The PACE and partnership programs look very much like those that are being designed for dual eligibles because they integrate both the acute care side and the long-term care side. Family care as a whole does not currently integrate the medical side of things. They only are working on the long-term care side. So, looking at some of the plans that they have, item number 6 of the 9 items that they listed was to support more integrated, cost-effective options in place of 24-hour, 7-day-a-week staffing. So they said they're going to arrange and support a range of services. I kind of use support and arrange there a lot, but anyway, that support person-centered outcomes and self-directed care. So we get back to, well, what is it they're purchasing? That's kind of a favorite thing that Jason Helgerson looks at too. He really does believe in performance measures. So they were looking at things like technologies, such as alert systems and rapid response supports for people with an intermittent or unpredictable need for supports. In other words, if somebody previously, in order to be kept safe, had an overnight staffing person in their apartment or their home, if it was a group home, then what they would seek to do is to replace that with some kind of monitoring technology. And actually they've been moving pretty quickly on this one. So and Dane County was actually a forerunner. They started doing that back in the 1990s. They had something called the sound response system initially, in which they would have an open phone line to the room in which the person with the disability was sleeping. And they would eliminate the overnight staffing, and then if the person needed some assistance during the night, they would call into a fire station where there was somebody located that could rapidly respond to their needs. It's never really been tested in terms of a real emergency, as far as I know. If there was a fire or something like that, I think there might be some issues. But at any rate, there's supposed to be an assessment, as to whether or not those kinds of technologies are going to meet people's needs. And I know that in certain areas of the state, they've been moving pretty rapidly to implement that already. They talk about assistive technology and home modifications, and probably the thing that got ridiculed the most was Medicaid management systems to assure the accurate use of prescription drugs. In other words, they thought maybe they didn't need staff members to dispense medications if they had these automatic machines that would feed the person, whatever pills they needed at whatever time of day, and they would just take them and they wouldn't have any staff intervention. That's their idea. Now, there's been a lot of controversy in the literature about whether or not that actually saves money, and it can even be effective in some cases. And the other thing is they wanted to get consumers involved in the discussion about cost-effective models for providing 24/7 in-home care. Item number 7 talked about developing more effective housing options, and this kind of goes with the national trend of separating services and supports from housing. So I'm going to kind of skip over that. But what we see is, despite all these plans that sound really good on paper, we're seeing existing providers and residential providers getting rate cuts up to 50% or more, which is huge. And in fact, we had a meeting with the Department of Health Services that I'll talk a little bit more about, but I heard in some cases where people were getting rate cuts on their individual rates, 65, 75, 85%. Well, how can you provide a service that's very staff intensive with cuts of that nature? Well, obviously there's been some outcry related to that. I was invited to speak at a couple of forums along with a disability rights attorney named Rock Plato. He's the Rock. And we spoke at 2 advocacy forums so far that have been attended by more than 300 people, and there's one scheduled on August 2nd and another one that's coming up. The one on August 2nd is right in the heart of Scott Walker's base of support. It's right in Waukesha County, which is the most Republican county in Wisconsin. And so it'll be very interesting to see, if legislators show up there like they have in the previous forums, and what kinds of statements they make, because, one of the most conservative senators, state senators, some of you have maybe even heard about this guy, a guy named Glenn Grothman. He's been on MSNBC and some other channels, who actually serves West Bend, where Patricia works for the Threshold, got up and said, I can understand a 2% reduction. That makes some sense to me. But, we were talking about something a little less than this. But I don't get why a managed care organization can cut rates up to 25% or more. He said the most conservative, member of the state senate was acknowledging that there's something wrong with that pressure. So last week we did meet with the Department of Health Services. I provided an extensive report to my board of directors so they would know that we made the case very strongly. We talked about these cuts. We talked about adverse events that have already occurred because of transitions that have been made from residential services that were meeting people's needs to programs that were not meeting their needs, and the consequences of that. And in fact, I have 2 organizations that I direct. One's a 501c6, which is a trade association. The other one's a non-for-profit. And on the non-for-profit side, what we do is we operate a program for the Department of Transportation that Overall statewide, with the participation of our members and others, it employs about 350 people cleaning rest areas. We also put on an annual conference. Well, over on that side of the ledger, we have been collecting funds that we call the Family Care Consumers Legal Action Fund. So we've been supporting efforts on the part of the ROC to represent people in appeals and other actions. Well, he's getting ready at this point to file a federal lawsuit. Just yesterday, I got notice that there were 60 notices of discharge provided in the northwest part of the state, which would be Menominee, Eau Claire, communities up in northwest Wisconsin, where two of the three organizations that were on the Legislative Audit Bureau's watch list for financial insolvency have been making very dramatic cuts in rates. And we expect probably within the next week to see from other providers another 60 notices of discharge going out. Because frankly, when you get a cut of 50%, what are you going to do? If you stick with it, you're putting yourself at risk as a provider, because in fact, you're assuming some liability. You're saying, I can continue to do this service in a quality manner for 50% less. And these providers are saying, I'm drawing the line here. You cut us 1 or 2 years before this, and that's it, no more. We're giving discharge notices. Managed care organization, you figure out where these people are supposed to go next. I hope you can keep them safe. So there's some other issues that have been noted regarding our family care program that you want to avoid at all costs as you put things together here. First of all, right from the beginning, providers were excluded from the care management team. So they would be making decisions based on the identified outcomes of the person, how they were going to best meet those needs through something called the RAD process, the Resource Allocation Decision-Making Process. So they got RAD all right, and they would make these decisions without any provider input based on a discussion they might have with a 94-year-old woman who's supporting her 62-year-old son. In fact, one of the things that happened in West Bend that Patricia can tell you about is that the 62-year-old, or however old he was, I forget, somewhere in that neighborhood, was being denied a day program by this managed care organization based on a care management meeting with this 94-year-old woman and her son on the basis that the 94-year-old was a homemaker and therefore her son could just stay at home with her. Well, they appealed and they won on that one. The other thing is the use of a functional screen to set the per person per month payments to managed care organizations and provider rates. One of the more insightful comments made by the Department of Health Services Deputy Secretary Kitty Rhodes in the meeting we had last week, when we were bringing up issues that had arisen during forums about how badly these functional screens were being done, she basically said something to the effect of, well, if we're not getting it right at the front door when we first assess a person's needs, it's going to affect everything all down the line. Because they're using the long-term care functional screen, which was originally developed to measure the support needs of people who are frail and elderly, and for people with physical disabilities, but does not translate very well over to intellectual and developmental disabilities, to set those rates. And if they're not even doing the interview properly, which calls for getting information from collateral contacts who are in the room, not just interviewing the person with a cognitive disability and taking their answers as gospel, but probing a little bit and saying, yeah, is that really the case? And in fact, when we were having issues last year, the department actually ordered the MCO to go back and redo a whole lot of assessments, which made a change in the rates that organization was receiving, and was able to pull back on some of the discharge notices they gave last year because of the increased funding. So it does have an impact. I'm going to talk a little bit more about assessment down the line here. I know I've only got 15 minutes left, so I'm going to try to squeeze the rest of this in here. The other thing that we've seen is that, and this is really one of those strategies where you go, huh? Why are they doing that? Because what they've done is, in some cases, they will repeat the functional screen 2 or 3 times a year in order to saying the person's gotten better, okay? Intellectual developmental disabilities, the person's got better. Now they can make a meal, or at least they say they can make a meal even though they don't. And that was a strategy because if you were setting provider rates based on the acuity of the person on that measured, then you would drive down the provider rate, right? Well, it shoots them in the foot because the next time the department goes and tries to figure out what their funding level should be, it also drops the managed care organization's funding level. So I don't know why they did that, but that was a strategy they were using for a while. And then there are these evergreen or perpetual contracts that managed care organizations are entering into with service providers, which basically don't get renewed every year, but you just put one contract out, doesn't spell anything out about rates, and oftentimes rates are changing 2 or 3 times a year for providers. Well, let's step back and say, okay, so why did Wisconsin go wrong on this whole thing? I mean, what is it, if you compared it to the other states, the other 3 states that are doing managed care for people with developmental disabilities, what are some of the elements that caused it to go that way? Well, I'm going to share information that actually came from a report by Bob Gettys, who's the former executive director of the National Association of State Directors of DD Services. That's a mouthful. And Nancy Thaler is the current director. And basically, it's available. You can look at the full report. I gave you the link here. And it highlights the experience of 4 states, Arizona, Michigan, Vermont, and Wisconsin. Now, similarities and differences between them. In Arizona, Michigan, and Vermont, managed care plans were put into effect statewide right off the bat. They didn't try to do it incrementally as we did in Wisconsin. And therefore, you know, some of the systems that you would need to manage the system had to be in place from the beginning, like something basic like a case management information system would be good. Or payment systems that were different among 9 different MCOs. Like having one payment system would be an advantage. In Wisconsin, they basically limited participation to adults, and it has been and continues to be phased in over multiple years. None of the states use commercial health maintenance organizations. So the private insurer didn't gain a foothold in these states, but is now gaining a foothold in some other states. In Kansas, Amerigroup put in a successful proposal to operate managed care for people with intellectual and developmental disabilities. Amerigroup is a for-profit company, just bought out by WellPoint. And so they're gaining a toehold in long-term managed care for people with intellectual and developmental disabilities, and we think that there are going to be more and more opportunities for those private insurers to come in. In Arizona and Vermont, it's an agency of state government that functions as the managed care organization. So they don't get the benefit of pushing it off so that they can, you know, assign accountability to another organization. But what they do is really more effective in some ways because they manage the risk at that level. They get a capitation from the federal government, and then they have to manage the risk downstream. In Michigan and Wisconsin, long-term services are purchased through risk-based contracts with a network of area-wide MCOs, as I've talked about. In Michigan, seems to be pretty successful. In Wisconsin, they're the existing or newly formed nonprofits. In Arizona and Vermont, state government assumes 100% of the financial risk. In Michigan and Wisconsin, state government shares risk with the MCOs. Michigan limits that risk to 7.5% over the MCO's annual contract with the state, which seems fair. Wisconsin does not have a reinsurance threshold, does not do risk sharing, although because the state is the ultimate guarantor, what they do is for the organizations that are financially struggling, they've been making supplemental payments to them at the expense of the other managed care organizations. So they don't put in extra money. They steal from the other organizations in order to make these organizations that are struggling whole. In all of the 4 states, a variety of administrative arrangements exist. In some, the state DD agency still has a role, in others it was dissolved. So we no longer have a state agency at the state level that really gets what services to people with intellectual and developmental disabilities should be all about, like normalization, community integration, et cetera, et cetera. So that might be a problem. In Michigan, person-centered plans are developed by a full IDT. In fact, once they're developed, and sometimes lawyers come to these meetings in Michigan. I went and visited one over in the Macomb, Oakland area outside of Detroit. And what I learned was that sometimes lawyers are brought to these meetings because the families know whatever goes into that plan is going to get funded. So that's the important document. In Wisconsin, as I mentioned earlier, a care plan is developed by a social worker, nurse, and participant or the guardian to the exclusion of providers. Although providers can be asked in some cases they are. It's not necessarily the norm. So I want to contrast some things between, this is my work, Michigan and Wisconsin. And I did this because there was an Employment First initiative that our APSI organizations and some of the other organizations aligned, advocacy organizations like the state P&A agency and some others, were proposing that Governor Walker issue a executive order making Wisconsin an Employment First state. And, you know, I don't know if anybody's seen it, but the case for inclusion that was just issued by UCP, they do a report that kind of compares and contrasts states along certain dimensions. In promoting productivity, Michigan was number 1. They have a managed care system. We have a managed care system. So I was in, and I think we're 38th in promoting productivity in the country. So I wanted to compare and contrast things that, you know, they have that we don't, and so forth and so on. In Michigan, providers are members of the planning team. In Wisconsin, they're excluded. In Michigan, they have defined financial risk sharing between the MCOs and the state. In Wisconsin, there's no risk sharing. In fact, there's no real allowance for outliers, although they just put some kind of adjustment in there for people who cost more than $8,000 a month. There's 2,800 of those people in the state, and they're supposed to be adjusting for that inside the capitation. But we don't see that that's affecting the MCO's behavior at all. In Michigan, person-centered plans funded at 100%. In Wisconsin, services are subject to the RAD, the Resource Allocation Decision-Making Process, and cost-cutting efforts on the part of the MCO. In Michigan, they seem to get best practices in service delivery for people with intellectual and developmental disabilities. In Wisconsin, there's limited experience at both the state level and at the MCO level. Well, you know, Gettings did say that there were some benefits to manage long-term care. I guess in this scary presentation that I've just been giving you, this might be the bright spot. First of all, you know, you can if you control costs and provide access, you can eliminate waiting lists and eventually create that entitlement to long-term care. It gives you flexibility in designing supports around the needs and preferences of individuals. We now see supported employment in parts of the state we never saw it before. It promotes prudent use of fiscal resources, supposedly. Better coordination with acute health care, if in fact that was taking place, and a fixed point of accountability. Some of the weaknesses that Gettings mentioned was that really, when it came down to it, a lot of the supports, at least in the initial stages when he examined things, were very similar to those that existed under the county systems. They didn't actually go out and grow a huge provider network just because managed care came in. They were using a lot of the same providers, providing a lot of the same services. There's also, of course, and I think this is kind of one of the dangers of the ACO, in fact, is there's potential for medicalizing ED supports. The learning curve for stakeholders in the state service system is very high. One of the things that we noticed as we were going out around the state starting in December of 2010 was people didn't know what their rights were. They didn't know how to speak the family care language. And so for them to even think about an appeal, you have to start at square one. Well, this is how you get services. You have to identify outcomes. You go through that resource allocation decision-making process, and you have certain appeal rights that are listed in our statute. Nobody was making anybody aware of any of those things. And so just even talking that family care, managed care language was difficult, especially for consumers and families who had kind of grown up under legacy systems. And then he said, this is not me, this is him, Big Gettings said, applying managed care concepts to long-term supports are of questionable value, according to what he thought. One of the things I want to mention is that some states are tempted to put populations together. And I hope you don't go down this way, because people with intellectual and developmental disabilities have very different needs from people who are frail and elderly in terms of their status. People with IDD can come into a system when they're 18 years old, if it's designed for adults only. They can live till 90. A frail or longer. A frail elderly person may only need care at the end of their life after they've exhausted their own resources and they need to turn to Medicaid for funding. People with intellectual and developmental disabilities often need assistance in directing their supports, whereas the frail elderly, although they're in poor health a lot of times, can actually participate in directing their care. And people with intellectual and developmental disabilities, supports really should be based on normalization concepts and active treatment. Now, one of the things I found is I've gone out and I've actually done some Googling on this one, Google normalization, see what you get. I mean, a lot of things I learned in the 1970s and 80s, they're just not there anymore. You have to go to libraries to find them. So, you know, younger generations kind of coming into the system don't really understand the underpinning because it's not out there in front of them all the time. It's just assumed. And in the frail elderly, they, you know, what can happen is care can be directed at avoiding more costly support. So the intention is to keep somebody in their home as long as possible to prevent admission to assisted living and nursing homes. So it's a different kind of emphasis. My top two recommendations for any state that's getting into managed care for this population is that if you're going to use an assessment for rate setting, they darn well better be valid for predicting the support needs of people with intellectual and developmental disabilities. And I really think the supports intensity scale is probably the best one out there. There's a comparison that's been done between the inner RAI and the CIS that was done by the Macomb Oakland folks, which I thought was a pretty good one, just points out the differences. The CIS really is a strengths-based assessment that talks about what it takes to participate in all the relevant community environments. So you get more information, plus it looks at more extensive behavioral and medical information than some of the other assessments that I've seen. Rate setting must be as transparent as possible, and that is rate setting not only to the MCOs, but rate setting and payments to providers. You need to know how they're formulated. You need to be at the table when these decisions are being made about how this is going to work. Because hidden assumptions should not drive funding. Provider payments must be bought based on their costs of providing service, not on somebody's idea or some kind of correlation between claims data, which may be inadequate, and assessment data. And that's actually right now in Wisconsin, that's how our system is funded. It's between claims data in one restricted part of the state, and it's really the pilot counties, and the long-term care functional screen and supposed associations that were identified through regression analysis. Well, I don't think that's the way to do that. I think you need to start from the ground up and make sure you're doing a great assessment and looking at where people do need support in their communities and building the rate that way instead of, you know, through some kind of arbitrary kind of regression analysis. Now, Access, the national organization that I'm on the board with, has sent a letter to Secretary Sebelius, and in fact, CMS is asking us for a meeting. They canceled the meeting that I listed here as August 6th. We're probably going to meet later in the month now. The CMS isn't all that together sometimes. But they have an intent to issue sub-regulatory guidance on managed long-term care this summer. And so we responded with this letter and the letter stated the concern and listed, I think, 12 protections that we thought should be in place for beneficiaries, those people who are receiving services under managed care. And I'm not going to go through all these. If you want, I can, I'm sure that the Resource Center can provide you a copy of these and maybe even get you a copy of the letter. But there are a number of things that we've said that need to be put in place in order to address those things. One of the things I think is important to realize is that managed care is not a panacea. It's not going to solve all the problems in terms of cost, access, quality, etc. And certainly, well, our experience is that it actually has reduced choice. So you need to keep expectations reasonable. And there was a paper actually that was published in July 2011 by the National Bureau of Economic Research, which was titled, "Has the Shift to Managed Care Reduced Medicaid Expenditures? Evidence from State and Local Level Mandates." And their bottom line was, managed care achieves savings largely through reduced prices rather than lower quantities. And they said basically that it lowered spending significantly more in states that started out with generous reimbursement. Well, guess what? I think New York's in that category. So I'm sure that they've got some kind of target figure that they've got in mind as far as savings go. And it suggests that if Medicaid provider rates are particularly low, then Medicaid managed care is unlikely to reduce spending. And I think that's what we're seeing in Wisconsin right now. The ACO is one alternative to the managed care models that we've been experimenting with in Wisconsin and other states. There's also standard fee mechanisms that could be set up, and that's one example. I'm doing some consultation work out in North Dakota. We're restructuring the payment system, and the way we look at it is we set up an individual budget allocation that's based on the supports intensity scale. And then from that, that individual budget allocation is used to purchase services based on rates that were set by a study of provider costs, so that you know when you go out into the market and you want to buy something, you can actually get it. So that's maybe a unique concept, but elements of this can be built into your system even if it's a managed care system. So that's the extent of my presentation, and thank you all very much for your attention.
Thank you very much for the presentation. I think it's in keeping with the theme week here at Chautauqua Institution, which is crime and punishment. I think there's an awful lot of similarities to some of the things that I know we're experiencing here in New York State as a provider to some of the things. So thank you for some tangible pieces of information that we need to look at and look toward advocacy and fighting the advocacy for the people that we support. Now it's time for lunch, and I have just a couple of instructions. Hopefully Vicky's around to correct me if I do this wrong, but